Hey, Nora,
Hey, Matt.
how do you make holy water?
It's a great question. How do you?
You got to boil the hell out of it.
I'm excited to figure out what the relevance of that was to the topic
Well, this
we're
is a
covering
sacred
today.
space. We're recording, so got to bless it.
Perfect. We're done.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cash Like Moral Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we are responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Welcome back to the Curbsiders. I'm Dr. Matthew Frank Watto, here without America's primary care physician, Dr. Paul Nelson Williams, but filling in is a very capable crew. And with me is the editor of the Curbsiders Digest, Dr. Nora Taranto. Nora, how are you doing?
I'm doing great on this Tuesday night. How are you?
I'm excited. We have a lot of articles to talk about today. We're going to talk about Finerenone, which is everyone's favorite for heart failure. We're going to talk about long-term oxygen therapy, like one of the 25 new pneumonia vaccines we're going to talk about, and we're going to talk about the equations for predicting cardiac risk. But Nora, before we get to that, and before we introduce our co-hosts, what is it that we do on the Curbsiders?
We are the internal medicine podcast, and we use expert interviews to bring you clinical pearls and practice-changing knowledge.
Yeah, and today we have with us some experts at reviewing articles. I would not consider myself one of them, but we have with us the great Dr. Rahul Ganatra. Rahul, how are you doing?
I'm doing great. How are you?
I'm always great when you're here because it calms me down. I feel like, we have somebody that knows what they're doing helping us review articles, so thank you.
Oh, that's not justified at all.
It is. And then with you, also joining us is Dr. Alex Chaitoff. Alex, you've written for the Digest for a long time now. I've really enjoyed your writing. Thank you for joining us on air finally.
Thank you so much for having me. And, I consider myself, as a trainee of Dr. Rahul Ganatra, really an honor to be on with him specifically.
Yeah, so you got to be in real world journal clubs with him. Now we're in a podcast world journal club with him.
I have to say, Alex was like the only resident who ever read the papers, the only person who was like sitting up straight in a chair. I noticed, Alex. I noticed.
This is tracking why Alex is someone that is, volunteered to write for the Digest for several years now, and we're very happy that he has done so. Well, we have a lot to get to, so let's start off with this, what is called the Fine Arts Heart Failure Trial. Nora, pause for your take on this name. Paul's not here, so I need someone to critique the name of this. What do you think?
I like this one. It isn't my favorite of the night, but this one's a good one. It has a nice name to it that includes most of the drug name,
Yeah, I feel like Finerenone drug trials, the three that I've reviewed, what is it, Fidelio, Figaro, and now Fine Arts HF. Yeah, I like all of them. And so this is by Solomon et al., Finerenone in heart failure with mildly reduced ejection fraction, and it appeared in the New England Journal in September of 2024. And this was a study. Basically, the background here is we had this TopCat trial back in something like 2014 that was looking at mineralocorticoid receptor antagonists, MRAs, like spironolactone, for heart failure with preserved ejection fraction. That ended up being a negative study, but that when they went back and sort of looked at adherence to the protocol, it seemed like in sites that actually, where patients actually got the drug, it actually did help. So some heart failure doctors have really thought like, hey, maybe these MRAs actually will work. And Finerenone is a non-steroidal MRA, so they wanted to check that out for heart failure with preserved ejection fraction. And that's where we get the Fine Arts HF trial. I don't know, Rahul, have you heard people talking about this?
I have only in the context of CKD. The studies you mentioned generated some excitement about the use of this drug in patients with CKD. So this is the first study I'm aware of in patients with heart failure. I'm excited to hear your take on it.
Yeah. Yeah, that's right. So the other trials, the other named trials with Finerenone showed that it was, you know, it was kidney protective. And it also had some cardiovascular benefits. And so that also probably led to this. So this was a trial, a randomized trial, Finerenone versus placebo in over 6,000 patients. So about 3,000 in each group. And patients had to have heart failure with preserved ejection fraction with an EF of 40% or greater. And they followed them out, and they found in the Finerenone group, they found about 1,083 events versus 1,283 events, respectively, in the placebo group. So this was a significant reduction in the composite. The primary composite outcome was cardiovascular death or any new heart failure event, basically like somebody seeking care for heart failure. So this was deemed a positive trial. Predictably, because this is a non-steroidal MRA, there was more hyperkalemia in the treatment group than in the placebo group. And they did not see the renal benefit in this that they saw in the other trials. In fact, some patients had some renal events like decrease in GFR compared to placebo. So comments, questions, what do you all think about this study offhand?
I have a question.
Oh, yeah, go ahead, Rahul.
I mean, Matt, you mentioned the results of the TopCat trial, which I think is what, those of us in general medicine who've had patients with heart failure will be familiar with. I'm sort of struggling to know how we reconcile these results with the findings of TopCat, especially given the kind of methodologic irregularities of that study. And the fact that this tested a different drug. I mean, do we know anything about, these medications as a class? How do we reconcile these results with TopCat?
Yeah, and the authors listed that as a limitation that we don't know for sure if we can extrapolate these findings to other MRAs. As far as I know, this is the only non-steroidal MRA right now on the market. And fortunately, because we had recorded one of these episodes at the time you're hearing this has already aired with Dr. Kittleson. We recorded a HFrEF and a HFpEF episode, and the day after we recorded, she emailed us about the results of this trial, very excited about it. And I had a chance to ask her, what do you think? Like, how do you think this is going to be interpreted? Because this is a very expensive medication and spironolactone is cheaper. So do you think like people will start using that if people can't afford Finerenone? And she said she does think that is going to be the case. She does think this will get incorporated into guidelines, and people will probably take this as more of a validation of what we thought should have happened with TopCat, where TopCat should have shown benefit for HFpEF if everyone got the study drug as they were supposed to. And so I think that people are going to be excited about that. And Rahul, that gives me, I know Alex did a bit of a back of the envelope calculation about this this cost question that we're getting at here. So Alex, what did you find out about this? Because this is quite an expensive medication at this point in time.
Yeah, I was talking with one of my friends, a cardiology fellow, Dr. Alexander Zeitlin, and he was pointing out this kind of, as we were talking about this huge discrepancy in cost and this questionable benefit that already exists for spironolactone. And when you actually do the back of the envelope calculations, and I say back of the envelope that way, no one checks the math too closely, but there's about a 6% percentage point difference in outcomes over 32 months. So you've got a number needed to treat around 15, 16, 17 to prevent one heart failure kind of worsening, exacerbation, hospitalization. Well, the good RX cost of this drug is between $630 and $730 per month. So you're talking, anywhere from $365 to over $400,000 to prevent a hospital stay potentially, which is way more expensive actually than the cost of a hospital stay. Obviously, there's benefit to not being in a hospital that is non-financial, but it's a pretty expensive medication for the benefit one's getting. And if you compare that with spironolactone, where a number needed to treat is higher, somewhere in the 20s to 40s, but the drug is only, the drug is so much cheaper that you're still only paying in the thousands of dollars to prevent a hospitalization potentially. So it is orders of magnitude more expensive per benefit that you're getting.
Yeah.
It also didn't seem like the improvement in like patient-related outcomes, like the KCCQ questionnaire quality of life index, was that dramatically better than placebo with this. And so I do worry a little bit about kind of whether patients will feel better on this per se.
Yeah. Yeah. So because they did the hierarchical secondary endpoints and the KCCQ questionnaire, it's like a cardiomyopathy questionnaire. It's a scale of 0 to 100, and the difference was 8 points. Well, there was a change of 8 points in the treated group and 6 points in the placebo group. So the difference between the two was like less than 2 points. Now, they said that symptom improvement of 5 points, when I was looking this up, 5 points or more is considered like clinically significant. So there wasn't a clinically significant difference between the placebo, if you look at the average score in the placebo, average change in placebo versus the average change in the Finerenone group. So I had the same question about that. And they did not bump from, like, if they were New York Heart Association class 3, they didn't go down to class 2 or 1. So they weren't like decreasing their class of heart failure based on this med. But still, for now, people are excited about this. So because we got a lot to get to end this, I do think you're going to see this make it into guidelines. And I do think because of the cost issue, you're probably going to see patients on spironolactone or Eplerenone just to sort of approximate this the best that they can, thinking that even though Finerenone is a non-steroidal MRA, that just your regular MRA should have similar benefit. So we'll see, but I'm excited to see how this one plays out. And definitely, I think people will be seeing this medicine prescribed more and more. Hey, listeners, after we recorded this episode and just before we published it, the CDC updated its vaccine guidance to include pneumonia vaccination for all adults aged 50 years and older. So it used to be age 65 and older. You only got it under 65 if you had risk factors. Well, now they lowered that age to 50 years and older. They should receive either PCV20, PCV21, or the combination of PCV15 followed by PPSV23 1 year later. So that's it, hot off the press. We didn't know about that when we made our discussion of PCV21, which you're about to hear, but keep that in mind as you're listening, and now you'll know where this new recommendation came from. Another thing that factored into the recommendation was the fact that they were trying to overcome health disparities and get people vaccinated at a younger age to improve outcomes. So without further ado, let's get to the discussion of PCV21. Nora, how many pneumonia vaccines are there nowadays? It's a lot.
Too many to count, really. And they all have numbers in them, so you really can't keep track.
And terrible names.
I know. They all sound like one another. It's just, it's rough. It's rough.
Well, I think for this one, we should just use the abbreviations like PCV20, PCV21, so we're not saying brand names when we can.
Love it. So yes, I'm going to talk a little bit about the PCV21 vaccine trial, which just came out in the Lancet Infectious Diseases. And this was covered by Dr. Molly Heublein in Digest 57. And so just to give a little bit of background, the PCV21 vaccine was designed in order to try to reduce the risk of Streptococcus pneumoniae. This is one of the most common causes of community-acquired pneumonia, as well as invasive pneumococcal disease, which can cause meningitis and bacteremia. While this in the last 50 years has had a lot of severity in both children and adults, the vaccination strategy with kids has actually dramatically reduced the rates of invasive disease and fatality in kids, such that adults actually now have a higher rate of invasive pneumococcal disease than kids do. And with the vaccination strategy with kids, this has actually changed the strains of pneumococcal disease or serotypes that cause invasive and severe disease. And so they're no longer covered as well by the infant vaccinations. And so, just as a reminder, before we jump into this study, there are two different types of pneumococcal vaccines out there that you may have heard about. There's the PPSV23. This is polysaccharide vaccines, and these don't activate T cells quite as well. And then there are these pneumococcal conjugate vaccines, or PCVs, and these use a polysaccharide protein complex to trigger a more robust immune response. And so over the years, the PCVs have added serotypes or strains of pneumococcal disease that they cover, and that leads to PCV21.
And Nora, the polysaccharide vaccines, from what I was reading, they don't confer as strong because they're not activating the T cells, and then you're not getting that B cell sort of like memory, that they're just not lasting as long. So that's why patients sometimes, if you're vaccinating younger patients with them, it's every 5 years or so they need to be revaccinated.
Yep. And I was speaking with one of my infectious disease colleagues about like the cohorts of patients that you would use that vaccine in these days. And the primary cohort is if for some reason you're either asplenic, so you don't have a spleen, or you're functionally asplenic, and or just at risk of infection with encapsulated organisms like strep pneumo.
Yeah.
Yeah.
Well, so if I'm a patient, because I am a primary care physician mainly, and when I'm telling patients that have already had their vaccine at 65, and I told them it was a one-time thing, and now I'm going to have to tell them, oh, now there's another new pneumonia vaccine. I imagine patients are going to be like, what the heck is with all these pneumonia vaccines? Every couple years, there was PCV 13 and PPSV 23, and then there was the 15 and the 20. You tried to give me that. Now there's a 21. You're telling me I should get that too. Like, what is happening? Are these companies just trying to make a ton of money off of this?
Great question. I'll start by just giving a tiny bit of the background for PCV21. And so the study that led to the CDC's advisory committee to recommend PCV21 was called STRIDE 3. And this study compared PCV21 to PCV20. And so you'd think that those would cover basically all of the same strains of pneumococcus, but in fact, they cover dramatically different sets of bacterial strains. And so PCV21 doesn't just add one strain, it actually covers 11 new serotypes of pneumococcus. And so the overlap is 10 serotypes. And so the study compared primarily immunogenic, like antibody responses to the vaccine for PCV20 and PCV21 for those serotypes, and then also found superiority, as you would expect, in terms of antibody response for the 11 additional strains of pneumococcus. And those 11 strains contribute to a majority of the invasive, like really aggressive and severe pneumococcal disease that causes death and morbidity in adults. And so it covers a dramatically increased percentage of the invasive serotypes for pneumococcus overall in adults.
Yeah, so they're claiming like 80-20 benefit, basically, like, this is more bang for your buck. It's covering a lot of the like 80% of what's causing a lot of the pneumonia.
Exactly. I think the number that they gave in the CDC report in June that led to this recommendation for PCV21 was PCV21 covers around 85% of the strains that cause invasive pneumococcal disease in adults.
Alex or Rahul, any burning questions or comments about this?
Yeah, I was talking to a resident about this today, and this particular resident had done some work with the Indian Health Service in the past, and he was telling me about in addition to the 8 new serotypes that the PCV21 covers, they have omitted coverage of one serotype, which is serogroup 4. And that serotype is thought to be more common, I never knew this, in states in the western United States and including on some Native American reservations like the Navajo Nation. So it's going to make the decision making a little complex at a population level for how, to take into account vaccination decisions in areas where there's thought to be a high prevalence of
Yeah.
serogroup 4. Nora, I don't know if you came across anything in the MMWR that would be useful for advising clinicians counseling patients in those regions.
Yeah, and I've used this actually myself already. There's a great app called Numerex that you can use and will risk stratify patients based on both their own comorbidities and whether they live in the West. And so they're actually updating that, and they have a kind of disclosure whenever you're opening it, and whenever it seems like PCV 21 is one of the options, with the like updated recommendations for people who live in the Western United States. And it seems like primarily the patients that you should think about PCV 20 or PCV 15 or 13, which do cover serotype 4, is patients who live in the West who have one of these risk factors for serotype 4. And so that seems to be right now primarily patients who have unstable housing. That's like the main risk factor that they've identified.
Yeah, it's a shame that it doesn't just cover everything, and then
Yeah.
we could just
Yeah.
get rid of the other pneumonia vaccines and just have one, because from what I was reading, there's just the one that they recommend for kids, and
Yeah.
it's a much easier recommendation, but this is like one of the more complicated vaccine recommendations, period. Just
Yeah.
like, if you're above 65, you can get this, and if you've had this one in the past, then do this. I think it confuses patients and clinicians, and so the app sounds great.
Yes, highly recommend. I've already used it like 5 or 10 times just in the last couple of weeks. So,
Alex, any other questions or comments on this? I know you do primary care as well.
No, I think the implementation issue is gonna be tough with having people redo, kind of go back and get another vaccine, especially as we're adding more vaccines each respiratory season. And the researcher in me is just knowing that some good pharmacoepidemiology studies are going to come out, trying to figure out what is the actual patient benefit to all of these, because right now so much of it is based on those seropositivity studies as opposed to running new trials every time. Looking at hard endpoints. So it'll be a really great opportunity to use some of that observational
Yeah.
data and figure it out.
Yeah. If you're a patient and you just got PCV 20, are you going to get PCV 21 just to add those extra serotypes? I don't know the answer to that, and I think for some patients it's probably not worth it if they're lower risk, but maybe for your highest risk patients. But I think at this time, the guidelines are just saying get either or, right? It's not, you don't have to get both. You can get
Exactly.
PCV 20 or PCV 21
Yep.
and consider that done. And there's
Right.
no revaccination recommendation at this time for people over 65, right?
Not yet. And yes, this study was done in patients who were naive to pneumococcal vaccination. And so there are, I think, 3 separate studies that are looking right now at patients who are immune compromised as well, which this study did not include. And then also patients who have been vaccinated already to try to clarify.
And just before we go to Rahul's article, I was just going to, as filling in for Paul Williams here, Stride 3. Now, Paul, like Nora and I like to judge trials based on how cool the word is.
Obviously.
Paul judges it by how well that it fits, like, the acronym. And this one is like, it's Stride 3, and it's safety, tolerability, immunogenicity. I don't know where they got the R from. It just falls apart after that. So I think they used double blind to get the D for Stride. I don't know. Nora, this is bad. This is
Bad.
not,
Well, yeah, fine arts also, I couldn't find a T in there.
but it's cool. But it sounds cool. So that's why they get
It does sound. I also looked up. I spent like 10 minutes trying to find Stride 1 and 2, and I don't know where they are, and I don't think they relate to PCV. Is all I can say from my limited sleuthing.
Okay. All right. Rahul, tell us about what you reviewed, and I believe we're going to talk about long-term oxygen therapy.
Yeah, absolutely. Well, I can tell everyone's hungering for a cool trial name, so I've got one that's got an X in it. So brace yourselves.
X is
Um,
cool, as Elon Musk has taught all of us.
all right, moving right along. This one is the REDOX trial. This is a study by Ekstrom and colleagues, and this was published in a September issue of the New England Journal of Medicine. And this is a paper that was actually covered by Dr. Laura Glick in Digest number 57. So, the main question that the redox trial was asking was whether long term supplemental oxygen administered for 24 hours a day would be non superior to oxygen for 15 hours per day with respect to all cause mortality and all cause hospitalizations at 12 months. So, Matt, have you ever heard of a non superiority trial before?
No, it sounds non-inferiority, yes. Non-superiority, no.
Yeah, no, the confused look on your face is justified. I have asked around quite a lot on, among my friends and on Twitter, and I have not found anybody who's had familiarity with this trial design. But let me tell you what they did, and then we'll talk about the interpretation a little bit. So these authors used a registry of patients receiving long-term supplemental oxygen at outpatient clinics in Sweden. And their objective was to compare outcomes among 241 patients who were all in their mid 70s with severe hypoxemia. And that was defined as an SpO2 of less than 88% at rest, or less than 90% if they had evidence of CHF or polycythemia. So patients were randomized to get oxygen prescribed for either 24 hours per day or 15 hours per day. And adherence to those prescriptions was assessed by mailed self-report surveys at 3, 6, and 12 months. And the top line results of this study were that this was a positive trial for non-superiority, which means that no difference was found. At 1 year, the rates of all-cause death or hospitalizations were identical in the two groups. There's 124.7 and 124.5 events per 100 person years in the 15-hour group and the 24-hour group. So putting that another way, the hazard ratio was 0.99, and the confidence interval confidently spans 1.72 to 1.36. So I would love to get into some of the things people pointed out when we were planning what we were going to say. Nora or Alex, do either of you want to bring up any things that you found confusing about this study?
I mean, I would love your interpretation and thinking about the protocol amendment and changes to the study design over the course of the study, just because that brought this article to our attention, I think, to begin.
Yeah. Well, before we recorded, Alex demonstrated the value of doing critical appraisal as a group because Alex and Nora, too, pointed out something that I actually didn't catch on my first read through. But I want to share this with you because I think this really should affect our interpretation of the results. So, practically speaking, I think it makes sense to appraise this study like a non inferiority trial because the comparison was basically less oxygen to more oxygen rather than a treatment to a placebo. And the authors did specify a margin for non-superiority. They specified that the lower bound of the hazard ratio needed to be greater than 0.67. And as Nora mentioned, the protocol was amended due to slow enrollment. Initially, it was greater than 0.83, but after realizing that they were recruiting patients really slowly, they changed the margin. Um, and one thing Alex pointed out before we recorded was that they also changed the sample size that was required to do that. So initially they had planned on something like 2,100 patients, and this was discoverable on clinicaltrials.gov. It's really buried in the manuscript. They mentioned that in the discussion, but in the methods, they talk about the sample size calculation being like, 10% of that. So let's talk about the red flags with this study that should affect our interpretation of the results. The first thing is that it's a little hard to know who to generalize these findings to because something like 1,000 out of 1,600 patients who were screened were excluded for reasons that were not specified. And I would worry about that if there was a difference found in terms of the chance for selection bias. But I find myself not really knowing who to apply these results to.
I was also struck by that in terms of generalizability with the fact that they've lost no patients to follow up and like everyone adhered perfectly to the amount of oxygen that they were prescribed, which just seemed wild.
Yeah. The loss to follow-up didn't raise an alarm for me because of the fact that this was done in a country where they had a kind of all population registry. And if the outcomes required any adjudication, then yeah, that would be really suspicious. But because this also demonstrates the value of using something like mortality and hospitalization as an outcome when you can adjudicate that. But yeah, the adherence to the prescribed oxygen regimen was like suspiciously good. The median of like 15 and 24. Okay, so yeah, so in terms of patients being excluded, makes it a little bit hard for us to know who to apply these results to. Nora already talked about the primary outcome and the non-superiority margin were both changed. And it's worth pointing out that the original margin would not have shown non-superiority. And inspired by Alex's back of the envelope calculation, we are going to include a hand-drawn diagram illustrating this in the show notes. And then the last thing I'll say is it's worth noting that the confidence interval does not preclude the existence of a smaller benefit of 24 hours of oxygen over 15 hours than what the study was powered for. And as near as I can tell from the protocol, they powered this to detect a 6% absolute risk reduction or greater. And so while the point estimate suggests that there's no difference between them, I think it's important to interpret that in the light of how the study was designed. And overall, I would say that this study really doesn't help me decide which patients might benefit from oxygen for 24 hours a day and which patients might be okay with 15 hours of oxygen per day. So not quite practice changing for me.
Yeah, and I think that's important why we do this, because this study generates an easy headline. 15 hours of oxygen is as good as 24 or vice versa. 24 hours of oxygen is no better than 15 hours of oxygen per day. And we can't confidently say that based on the results of this.
Yeah. And I do respect if somebody tells me, they don't want to be tethered to oxygen for, 24 hours a day. That's really important. And, the absence of a clear signal for harm of 15 hours per day would reassure me in, thinking about an oxygen-free period for, potentially up to 9 hours in patients who wanted to do that. But I think this study, particularly with the margin being changed and the sample size being reduced very much from what they had intended, those are both sources of bias towards equivalence in my view. So it's hard to know what to do with this.
It was also interesting just thinking about like patient quality of life and choice in this. I can't remember which table, but there was one table that looked at like at the end of the trial, who preferred which arm, like 24 hours versus 15 hours. And it was just interesting to me. I don't know what to make of this, but like the patients in the 24-hour arm, the majority of them preferred the 24 hours, and the patients in the 15-hour arm preferred the 15-hour arm. And so I don't really know whether patients prefer the shorter or the longer, whether like the oxygen actually makes them feel better, which it's really unclear.
I think in some ways it is like a testament to human adaptability. And a lot of the times the thing we get is the thing we're, happiest. Everyone loves the school they went to because they went to it. In some ways, I've thought that part was almost reassuring. And that was actually something I thought the trial, I know I said probably won't change practice in this moment, but I think it did really well. And I would love to see from more trials is these kind of patient-centered outcomes. I thought did a really nice job capturing some of those, even if unfortunately they can't really inform what we do at this moment.
Yeah. And if Paul were here, I know he would comment on the strangest adverse effect of all time. Nora, you pointed it out, so I feel like you have to talk about it.
I looked into the protocol to like try to find more about this, but they listed two serious adverse events, neither of which seemed related to oxygen as I could tell, but one of them was extirpation of a colonic polyp, which I don't know how on earth it relates or doesn't, and how it was collected as like an event. So if anyone out there can think of it, share with us.
Oh, that's great. And I love that. Yeah, Paul would really like that. That's kind of sad that he's not here because of it. He really would find that funny.
I had to like look up. I knew kind of theoretically what extirpation meant, but I was like,
Google that.
Is this what I think it means?
What does it mean? Because I didn't Google it and I don't know what it.
It's like destruction, right?
Destruction. Okay.
Like to
Yeah.
forcefully
To
destroy.
forcefully destroy, which
Could that be a good thing?
I mean, that's what colonoscopies do, right? They forcefully destroy colonic polyps.
I feel like
Yeah.
a middle schooler.
Hopefully
laughing at
there
this.
wasn't some sort of fire related. They were using cautery near the oxygen or something,
Mm.
and there was a fire. I wonder.
Maybe.
Oh,
But
It is
they-
actually, it is worth pointing out by virtue of the way the study was done, and many studies like this, this is going to underestimate adverse effects that are related to oxygen therapy, because they discuss in the protocol how they, I'm not sure why this was decided, but the decision was made to only report adverse effects that were thought to not be, mechanistically related to oxygen. So not looking at things like falls or burn injuries. Not exactly sure why.
Okay. All right. Well, we have one more topic to cover, and Alex, why don't you tell us about this? And this was another one from the digest covered by Jen DeSalvo in digest number 56.
Yeah. So we're going to talk about cardiovascular risk calculators, but before we dive into it, I just want to level set and say one of the reasons I find risk calculators so interesting are because for cardiovascular risk and statin initiation and use, it's one of the few areas where we actually look at the individual patient before us and give them a risk to say your chance of having an event in the next 10 years is this percent, as opposed to saying, for cancer screening where we say, okay, you've turned 45, you get this cancer screening now, or many other treatments. So I find that really interesting, but it means that we have to have good risk calculators that actually match up with how patients, how much risk they actually have of having a cardiovascular event. And for years, since 2013, we've used the pooled cohort equation to estimate essentially 10-year risk of atherosclerotic cardiovascular disease. And these models were developed from 5 cohorts. That's why it's called the pooled cohort equations. And there are several problems to them. They were initially, these cohorts initially started recruiting in the 1950s. So there's a lack of diversity. There's some overfitting because of that lack of diversity, they over predict risk potentially in certain groups. And frankly, a heart attack, I think, what a heart attack has changed even in the past 20 years as high sensitivity troponin has come online and such. And so there was this question of how well do they predict risk today? How well do the pool cohort equations really predict risk today? And it led to the development of the prevent equations. And I don't want to step out of turn here, but I feel like judging the acronym prevent, it's not a trial, but I mean, it's a pretty good one in my mind.
Yeah, says what it does.
Yeah, exactly. It's very factual.
Compared with anything else in medicine, I think it's pretty good.
It's much cooler. It's a much better name than pooled cohort equation as well. Yeah.
Yeah.
I just want to give shout outs where we can in medicine. There's so few victories. So few victories. The reason that folks and I kind of mentioned hypothetically, right, we can all think of reasons why having a cohort, having equations based on people who were recruited in the 1950s may not, work as well for today's, 2024 individual. But there was actually a study in 2018 where they looked at the pool cohort equation, and essentially they re-derived the equations using different cohorts that were more modern. And what they found is, without going into all of the statistics, is they found that actually the pool cohort equations, the ones that were developed to be kind of what we should use in 2013, not that long ago, actually overestimated 10-year risk of cardiovascular disease by an average of 20% across different groups. And this was most notable among Black adults. Essentially, 1/3 of Black adults would have had risk estimates that were substantially different than if they'd had the exact same risk factors, but were white. So this equation, needed some updating, and that's where the prevent equation comes in 2023. What's interesting about how this was derived is it's using data from 6.6 million people from a variety of different cohorts, dozens of different cohorts, and including claims data. So actually using data from Optum to derive new equations, and those were published at the end of 2023. And so the actual study, there was a lot of leeway to get a lot of lead to get us into the actual study, asked a question.
Yeah.
It asked the question, okay, so now we have these new equations, the prevent equations. We had the pool cohort equations that are still in guidelines. What's actually different? What is going to change? And so what this 2024 study by Anderson et al. Did was they used a nationally representative survey, the National Health and Nutrition Examination Survey, and they calculated everybody in it from 40 to 75. They calculated their risk of having a cardiovascular disease using the pool cohort equation, and then calculated their risk using the prevent scores, and saw how many people had significantly different rates of disease. How many people went from above and below, for example, 7.5%, where they would be recommended to have a statin. And the long story short is they said that 17.3 million adults would no longer be recommended to have a statin if the prevent equations were in the guidelines versus if the pool cohort equations were recommended by the guidelines.
And Alex, as you pointed out in our chat, before we had recorded while we were planning this episode, the comments section in the article on the JAMA website they were kind of funny, but people were just saying, like, we don't have any real world experience using these equations. You're sort of just retrospectively looking and trying to apply this model to say, like, how well would it predict risk? And I guess it sounded to me like they were saying we need to prospectively study this to see how it works. So how do you see this being put into place, or is it too early to start using this?
Yeah, I think one, as I was preparing this, it's when I learned that there were comment sections on journal articles. So, get out of the YouTube comment sections and go where the real action is over at JAMA. But yeah, I think, some really good points were raised. First of all, we already have a risk score. If somebody is hesitant to use a statin, is the answer to use a different risk score, or is it to get imaging like coronary artery, calcium scoring? If you reassess their risk and it is lower using the prevent calculators, is that an indication to deprescribe a statin? Well, certainly not in the guidelines to do so. And, we have some evidence on legacy effects of statins, that potentially the benefits of statins exist beyond, for some period beyond taking a statin, but we don't know how long that benefit, lasts for, if it's the same for everybody. And at the end of the day, this kind of all gets down to, it's not in the guidelines yet. We don't know if a statin is going to reduce your risk the same magnitude based on the prevent calculator, if the same risk thresholds would still hold, if cost effectiveness thresholds would hold, if they would change. And so it's really probably not ready for prime time in this moment. But given that the cohorts really that the score is derived from are so much more diverse, so much more contemporary, including patients recruited in the 2000s, it is probably coming to an MD calc near you soon, and frankly to a guideline near you soon, but not just at this moment.
Yeah, and I will say, you mentioned coronary calcium scoring, CAC score. For patients that are really on the fence about using a statin, but they're worried about the risk and they want to know a more personalized, individualized risk, usually I'm offering to check a coronary artery calcium score, which has usually a small out-of-pocket cost for people. Well, depending on their budgets, it's relatively small, usually under $300, sometimes under $100. And then I may check LP(a), which we've talked about on other episodes. At least one time it's recommended in a lot of guidelines to check that at least one time for all adults to help risk stratify them. And then you can check ApoB as well if you really want to get geeky about kind of trying to optimize their lipids, even for people who are on statins. But Rahul, did you have any questions, concerns about this?
Yeah, I mean, one thing I thought was cool about the prevent equation, even though we're not talking about the derivation of that, I mean, Alex described how, taking race out of equations is something we are moving towards as we realize how kind of made up and imperfect of a surrogate that is for other things. One thing that's cool about the prevent equations is that it does incorporate a social deprivation index to try to more precisely get at the social determinants of health that could affect cardiovascular risk. And in this study, they actually didn't use that variable because that information wasn't available in the NHANES data. But as far as what's different between the pooled cohort equations and the prevent equations, we're trying to better understand the social determinants of health. I think that's pretty cool. And this also takes into account the, urine albumin to creatinine ratio, the A1C. So it sounds like it has the potential to better classify patients, but since we don't know anything about long-term outcomes yet, at least not from this study, I don't know how this will be used.
Yeah. Yeah, I think there's, Alex, there's the base calculator, right, that includes the EGFR and statin use, and then the other, I don't forget how they termed it, but it's more of a honed in where they actually add the albumin creatinine as well.
Yeah, I actually think that's one thing they did well, or one thing that is nice about the prevent calculators, and that is they have a base calculator that essentially you could imagine has information that can be pulled from an EMR. In theory, social deprivation index, also could be, you have patients, zip codes in there, but it can be very quickly pulled. They then add these other things that do statistically significantly increase the discrimination of the algorithm. And they actually publish how much. And the answer is it's quite low. The C statistic goes up 0.005. So that's a pretty small increase. And so you shouldn't feel bad. Like, I don't think it was what they compared in this study. It was reasonable to not have things like the social deprivation index included. That's not throwing, their number is not going to go from 17.3 million to 2 million reclassified people. But I think it's really nice that the equations are kind of created, that you've got the gold standard. If you include everything, you have a slightly better equation, but also, hey, here's a simpler equation that's going to be easier to pull in routine practice without, all of these extra variables.
Is that how they interpreted and kind of changed the risk calculation based on statin use? Because isn't one of the differences also that prevent does include whether a patient is on a statin, which PCEs did not?
Yeah, so the prevents does include statin use, and in this study, they essentially, if someone was on a statin, added back how much cholesterol they would have, and then changed their statin use to 0 to try to figure out, okay, let's make a pure group of people not taking statins, which, they did some sensitivity analyses around to say, hey, look, again, how much we're saying the cholesterol is going to go up or down is not throwing off our number. The point is whether it's 17.3 million, 15 million, or 20 million, it's a big number is the point. But yes, that is something that the prevent equations have. And that also, to the points made earlier, is how does one use that in practice? Mm-hmm. I think it would be nice, I think it'll be good to have some more expert guidance before, in a guideline, a specific guideline of how to actually incorporate into practice before replacing the current equations that we use.
So, Alex, it sounds like this is not ready for prime time yet, but do you think this will be incorporated into guidelines next time they're updated?
As somebody who's never been involved in the guideline, I confidently say I can't imagine it not being included in the next guidelines. I think it's probably the future.
Okay. All right. Well, I think we should wrap this up. We've covered 4 topics. I think we did a great job. Had a lot of fun. I think we did some good work critiquing trial study names, as always.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
Amazing, Rahul. Crushed it. Still hungry for more? Join our Patreon and get all episodes ad-free plus twice monthly bonus episodes at patreon.com/curbsiders. You can find show notes at thecurbsiders.com and sign up for our mailing list to get our weekly show notes in your inbox, including our Curbsiders Digest, recapping the latest practice-changing articles, guidelines, and news in internal medicine.
And we're committed to high-value, practice-changing knowledge, and we want your feedback, so please email us at askcurbsiders@gmail.com. A reminder that this and most episodes are available for CME credit for all health professionals through VCU Health at curbsiders.vcuhealth.org. And a special thanks to all our writers and producers for this episode, all of us who just recorded tonight, and to our whole Curbsiders team. Our technical production is done by the team at PodPaste. Elizabeth Proto does our social media. Jen Watto runs our Patreon. Krista Chu-Manchu moderates our Discord. And Stuart Brigham composed our theme music. And with all that, until next time, I've been Dr. Matthew Frank Watto.
I'm Dr. Alex Chaitoff.
I've been and remain Dr. Rahul Ganatra.
And I'm Dr. Nora Taranto. Thank you and good night.